Venous thromboembolism, or VTE in short, is a relatively common complication with an incidence estimated at 2 to 4 per 1,000 hospitalized patients. The source of emboli in VTE is usually from a deep leg vein thrombi above the level of the knee, such as in the popliteal vein, the femoral vein, or iliac veins, which account for over 95% of VTE. From the large veins of the lower extremities, the emboli now travels along the venous route to the heart, navigating through the right atrium and right ventricle before it finally lodges in the pulmonary artery or its branches, depending on how big the embolus is. When a VTE goes into the lung, it is known as pulmonary embolism, or PE in short. The risk factors for VTE are similar to the development of venous thrombosis. There are conditions that cause stasis and hypercoagulability. So these include prolonged bed rest and immobilization, sitting on long-haul flights referred to as economy class syndrome, lower limb surgery, pregnancy, and the prolonged use of certain types of oral contraceptives, smoking, cancer, and nephrotic syndrome. When the thrombus detaches and moves, the final lodgement of where it gets stuck is dependent on the size of the emboli and the size of the vasculature. A venous thromboembolus nearly always ends up in the pulmonary artery or its branches. The final site and the clinical outcome would depend on the size and number of emboli, the location of lodgement of the emboli within the pulmonary arterial tree, and the patient's underlying cardiac status. VTE, as mentioned earlier, usually would end up in the lungs, causing pulmonary embolism. A large VTE which exceeds the diameter of the pulmonary artery branches will get stuck at the main pulmonary artery, giving rise to a massive pulmonary embolism, clinically referred to as unstable pulmonary embolism. Obstruction of the main pulmonary artery causes an acute increase in the pulmonary vascular pressure, leading to sudden increase in right ventricular afterload. The sudden stress causes right ventricular strain and dilatation, resulting in right ventricular failure and obstructive shock, often leading to sudden death in the absence of immediate surgical intervention. A slightly smaller pulmonary emboli may be able to navigate through the main pulmonary trunk, but go on to obstruct the proximal and intermediate branches of the pulmonary artery. In such cases, the patient may present with pulmonary hemorrhage due to the sudden rush of blood from collateral blood vessels attempting to perfuse the area affected by the occlusion. Pulmonary infarcts tend to occur with obstruction of distal branches of pulmonary artery when the supplied area does not have sufficient collateral blood supply. Pulmonary infarcts, though, tend to overlap with pulmonary hemorrhage. Small multiple emboli may be able to travel further down the branches of the pulmonary artery right to the precapillary arterioles. Chronic showers of small pulmonary emboli such as these then can cause vascular remodeling of the arterioles, which lead on to pulmonary arterial hypertension.